You may be surprised. Cancer patients want to live. They want to survive. And so they don't want to be upfront and honest with every symptom they have because they're afraid that we're going to stop their chemotherapy. And that means that they're not able to have treatment anymore, which means they might not be here much longer. Patients really get scared and don't want to tell us the truth about all symptoms.
Welcome to In Good Company, Elder Care in Your Backyard.
Candi Jordan is a dedicated nurse practitioner at Oncology Hematology Associates with more than 24 years of experience in oncology nursing, including 15 as a nurse practitioner. She brings clinical expertise and heart-filled compassion to supporting patients through every stage of their cancer journey, from diagnosis and treatment to survivorship and end-of-life care. Driven by passion and advocacy, Candi treats every patient like family, ensuring they receive timely, comprehensive support. Candi, welcome to our show.
Thank you.
Tell us how you got into nursing.
So as a child, I had the dream of always helping other people. So initially, my dream was to be a physician, and I wanted to be, just like everyone else, a pediatric physician. However, in my teenage years, my grandmother got diagnosed with cancer. And during her hospital stay, right before she passed away, I was able to spend some time with the nurse at the bedside, and she just made me feel so welcome to be in that space and to not feel scared. And so from that time on, I decided that I wanted to be an oncology physician. I then went to Evangel, and after a couple semesters of that, I decided that I really wasn't built to be a physician. I was more people driven. And so I decided to switch over to nursing. And so I switched over to Cox College of Nursing, where I attended and got my associate's degree. And then I got my bachelor's and my master's from MSU. And so I have only worked in oncology. Cancer is my passion.
Wow.
So that's how I got started.
Wow. Well, can you tell me about where you're currently working and about that?
Yes. So I'm a nurse practitioner at Oncology Hematology Associates located here in Springfield. We actually have 2 satellite clinics. We have one in Monette and one in Lebanon. And those are both open 5 days a week with a physician or a nurse practitioner present. We are currently located in the Holston Cancer Center here in Springfield.
And what kind of cancers do you guys specialize in?
So at OHA, we actually specialize in all cancers and blood disorders. So we don't do just one particular type or focus on that. So we'll see everything from breast cancer, lung, colon, pancreatic. We even see some ovarian. We will see testicular, prostate, and we do blood disorders too. So we have a leukemia, lymphoma, myeloma, and then some of the other blood disorders such as anemia.
Wow. So we're primarily focusing on elder care here. What are the cancers that you see the most in that demographic?
So we see a lot of colon cancer, probably a lot of lung cancer patients.
Okay.
And then our blood disorders, chronic leukemia is very common in the elderly. And as we age, our risk for myeloma also will increase. So we see a lot of those, quite a few lymphoma patients as well.
Okay. And since you treat everything, how much of that treatment is actually done in the clinic and how much of it's done outside of the clinic? Maybe, I'm assuming there's some treatment that happens and maybe in the hospital or some other setting, or maybe even in the home.
So most of our cancer patients are treated in our office. We have on-site chemotherapy administration. So they can have chemo, immunotherapy, iron infusions, supportive care infusions right there in the clinic.
Okay.
We do have to refer patients to radiation oncology, and depending on their insurance, that depends on where they go. But at Holston Cancer Center, we actually have radiation oncology in the building associated with Cox, and then we also refer to Mercy for radiation oncology.
Okay.
If they have to have a blood transfusion, we do have to send that to the outpatient services at the hospital.
Okay.
Very few patients nowadays have to have inpatient chemotherapy. There are certain regimens that do require multiple day stay in the hospital, but those are actually very rare, and we're able to treat more and more patients in the outpatient setting.
Okay. Wow. I guess I didn't realize that you did every kind of cancer
Just about.
out there. I'm assuming you have quite a large caseload.
We do. We see a lot of patients. Our physicians will see 20 to 24 patients a day. Our nurse practitioners typically see between 12 and 16 patients probably a day.
And are most of your referrals coming from general practitioners or?
General practitioners, we also get them from some of the specialists like dermatology or surgical cases. They'll see them in surgery and then they refer them over to us.
Okay.
We also take self-referrals. And the good thing about being, which I know we really haven't mentioned yet, but being a community-based practice instead of our hospital-based practice is that we actually do our referrals in-house and we usually can see patients within 1 week.
Oh, wow.
So we don't have a very long wait time. Now, if
That's
it's like
great.
a blood disorder, it may be like a 2-week wait. But for cancer patients that need cancer care immediately, we need to be open and be able to see them. And so we have to work our schedules around other patients. We might switch patients around provider to provider that day. So if there was patients to see a physician, but we have a new patient that needs to be seen immediately, then we can switch that to a nurse practitioner so that we can take care of all patients. So we don't like patients to have to wait for referrals.
That's amazing because I've actually heard a lot of places that ended up having to delay things quite a bit because of just the caseload and that sort of thing. And I love that you mentioned self-referral. How does that work? Or did somebody self-diagnose somehow, or did they come in and want just some sort of screening?
Yeah, so some patients will, let's say they have a history of iron deficiency anemia, and they're like, I haven't been treated in a while, and I think my iron levels are low. I want to be seen by someone. Or they may be seeing their primary care provider and they disagree with what they've been talking about and saying for their treatment. And so they can call in and say, hey, I'd like a referral for this. Sometimes it's patients that are outside of the area that already have a diagnosis and they're wanting to transfer care. So they may call up and say, hey, I want an appointment.
Yeah.
It may be that a patient has just received a message from the breast cancer center saying, hey, they found a lump. They're now telling me it's positive. And instead of waiting for a surgeon to refer to us, then they may just call and say, hey, I want to see you. Or in that case, if a patient has already established care with someone else and they're wanting a second opinion, that would be another reason why they would do a self-referral.
If somebody was interested in preventative screening, do you refer that out or do you do preventative screening?
So we do some preventative screening. Most of that is done with the primary care provider. However, when they're coming to see us, we're going to try to look and say, okay, you're over the age of 40. You now need your colonoscopy, or 45, you need your colonoscopy, or you're at the age now at 40, you need your breast exam. We need to go ahead and get you a mammogram.
Okay.
We also do some screening with lung cancer. So patients that have a high risk of lung cancer will order low dose screening CT scans to help do surveillance for lung cancer for smokers.
When you're looking for something that puts somebody at high risk for a different type of cancer, in those different categories, what are the things that usually, if they put it on some sort of history, you'd be like, okay, this is probably somebody that we need to at least screen?
So smoking is a big one, more than a 20-year pack history.
Okay.
And that's going to put you at higher risk for lung cancers, even bladder cancer.
Okay.
Chemical exposure can be another reason why you would have a higher risk for cancer. And there's also, in that case, we have a lot of military that have been exposed to different things over the years, wherever they served at, that's put them at higher risk for cancers.
Okay.
So we see
it's
that.
Primarily military, or are you talking industrial as well?
It can be industrial as well.
And what industry would pretty much red flag for you?
So back in the day, you would have people that would work in these factories that have a lot of chemicals and they were not using protective measures. So no mask, no ventilation. And so those patients are higher risk of having different malignancies. Benzenes was one, asbestos, that's another one.
Yeah.
Right now, Roundup has its lawsuit out there, but the thing is, you can't always prove that.
Sure.
And so I think that is what gets patients really riled up, is like, oh, well, I have these exposures and we know that can be a risk. how can I get something from it?
Right.
Besides having to get chemotherapy and having this bad diagnosis. But we really can't prove that.
Yeah.
We just know that sometimes those are factors.
Right.
Genetics is another one that can play into it. So we do genetic testing to see if patients have high risk mutations, or if they have genetic predisposition to certain cancers, or if their family is going to have higher risk. And so those are things that we can do in the office as well. We work with different companies that are able to run those tests for us.
Okay, that's fascinating. I think back in my own situation, when I just graduated high school, I thought I was making the big bucks because I took a job doing asbestos removal.
Ooh.
And I worked alongside guys who had installed asbestos. They were older, obviously. But, it was one of those things where I did that then. And I always, in the back of my mind, I'm thinking, is mesothelioma only going to be,
Right.
coming back to haunt me? But
Because you probably didn't wear the appropriate gear or mask. And
well, I mean, they gave us a mask, but, and looking back, it probably wasn't cared for. We didn't get, swap out filters and all the things that we needed to do. And so that's what makes me think, anybody out there who is, concerned and wants to get screened, telling them kind of what to look out for, what type of industry and the different things that might at least, because as I understand it, most cancers have a better prognosis the earlier you catch them,
Right.
correct?
Yep.
So
And prevention is key,
prevention.
but then early detection is
Okay.
very important.
So let's talk about prevention a little bit. When you say prevention, what do you mean?
So healthy diet,
Okay.
exercise,
Okay.
which people don't want to hear. I hear from my patients all the time. I'm like, do you exercise? Yes, I walk. Walking's great, but we need weight-bearing exercise. We need more exercise than just walking.
Okay.
And that's very helpful if we can keep a great diet with a weight that's sustainable and healthy
Okay.
with exercise. That's going to be very important to prevention.
Okay. So weightlifting, exercise, and when you say healthy diet, what do you mean?
So a well-balanced diet.
Well,
As I tell my patients,
and growing up, they
increase-
have I'm picturing
Right.
the pyramid.
the food pyramid, right?
the color on the plate.
Okay.
Color on the plate's always good for you. Do as I say, not what I do.
I'm the same way.
Exercise. I do
Yes,
exercise.
exercise.
The
That's
diet, that's a different story.
Yeah.
But eating, your fruits and your vegetables and making sure that you're getting protein. Our bodies need probably more protein than we give it, especially as we age.
Okay.
We see a lot of muscle wasting, which can lead into fatigue because elderly patients don't want to eat. They have a decreased appetite.
Right.
Or they're eating like one meal a day.
Okay.
But they need to make sure that they're eating small, frequent meals with high protein.
Right.
That's really important. Like you mentioned earlier, screening, that's part of prevention too, is catching it early. Women doing their self-breast exams, men checking to see if things don't look right. And if you find something, you act upon it and not wait and put it off.
Okay.
Yeah, they recently lowered the age for colonoscopies.
Yes.
That was a big thing.
Yep, from 50 to 45.
Right.
Yep.
Yeah, that's crazy. Yeah, what's interesting to me is that, it seems like they're tying more things habit-wise to different types of cancer, and prevention is starting to expand because, I never knew, I didn't know about weightlifting and that being,
Just general health.
factor. Yeah,
Yeah.
just general health.
And in my opinion, it includes weightlifting.
Yes, no, I 100% agree.
And, decreased alcohol use,
Sure.
no smoking.
Right.
The use of marijuana, that's a big one right now. That's not
Oh,
necessarily
really?
that healthy. It's not good for your lungs to smoke
That
that.
makes sense.
It's not good for your liver for it to filter through it. However, it is legal and patients do use it. But I have seen patients who have came in with abnormal lung scans because of them smoking marijuana.
So even with medicinal marijuana.
Yeah.
Okay.
So, just overall health is going to be the biggest prevention. I have to say another one on that. Sunscreen.
Sunscreen.
Sunscreen's very important. Apply
Yeah.
your sunscreen.
How much
Okay.
skin cancer do you see coming in?
We see more melanoma in my clinic because most squamous cell and basal cells, those are going to be taken by surgery. But we do see quite a bit of melanoma, and melanoma is deadly. It's something you don't mess around with.
Okay.
So decreased tanning bed use
That's good to know.
and sunscreen, very important.
So do you do surgeries in your group?
We do not do surgery.
Okay.
We do
Okay.
bone marrow biopsies in the office, but that is probably the only procedure that we actually do in the office.
Okay. And when you refer those procedures out, where are you referring those to?
It depends on insurance.
Okay.
Some will go to Cox and some will go to Mercy.
Okay. And just, if a diagnosis is being treated and that treatment is not going as you would like and not progressing, what happens then?
So we would prove treatment failure on scan. We're going to look for progression of their cancer on the scan. And we typically do imaging about every 3 months for most cancer diagnosis.
Okay.
Unless they're having worsening symptoms where we need to move that scan up.
Okay.
So after progression of disease, then we look and see what the next treatment option is going to be. And so we do use NCCN guidelines and FDA guidelines for treatment options for our patients.
Okay.
Could you walk us through what that means?
So NCCN guidelines is a national guideline consortium that actually tells us what has been studied, what has been proven to be beneficial in cancer patients.
Okay.
And so for, let's say, metastatic breast cancer, it used to be that all metastatic breast cancer patients would immediately have to go to IV chemotherapy. And then you were on chemotherapy basically for life. However, as we have progressed in technology and in research, we now can start these patients on oral medications where they can be on those oral medications for years before they even need to see chemotherapy. And so we're keeping them alive longer with healthier lives, better quality of life with better quantity of life.
That's awesome. That's awesome. And how long?
And so those guidelines will help us.
Are you currently doing any clinical trials?
We do clinical trials in our office. We are actually a partner of American Oncology Network. And so we are a community-based practice, physician-led practice. And so we do have research trials within AON. We also have research trials with industries, and we also partner with the community research of the Ozarks, which is with Cox and Mercy. So we have patients that are also within those clinical trials. Oftentimes we have to refer patients out for clinical trials because we don't have the newer drugs here. So we typically will do a phase 3 trial locally. But if it's an earlier trial, that's usually sourced out. So we usually refer to KU, MD Anderson, and then also Barnes for research trials.
Okay.
Up in St. Louis, right?
In St. Louis.
And is there anything exciting on the horizon?
Any exciting trials happening now?
I don't know about really exciting trials right now. I know my office has partnered with Dartmouth University to look at supportive care with patients, like what is their support at home and how does that actually impact their end result? Are they having better outcomes because they have support? So that is a new trial that we just opened up, working with them. So that's exciting. The exciting thing in the world of oncology has been the immunotherapy. So it used to be lung cancer, you got chemotherapy, and then usually you passed away. It would recur, and then we didn't have many more options.
Right.
And now we can keep these patients alive for a long period of time on immunotherapy.
Wow.
And it has been a life changer for these patients. And it's great to be able to see patients on these drugs for 5 years when we know that 5 years ago, if we didn't have these drugs, they wouldn't be here today.
Okay.
And so the immunotherapy has been a huge additive to our chemotherapy or to our treatment for these patients.
And you do that in your clinic?
And we do that in our clinic.
Wow.
Yeah. Immunotherapy first came out for melanoma patients.
Okay.
And then it went into lung cancer patients. And since then, it's just bloomed. And almost every type, not every type, but a high percentage of cancer types will actually benefit from immunotherapy, depending on their tumor markers. And so that has been life-changing.
Can I ask how immunotherapy works?
Yeah. So immunotherapy is working with your immune system to make the immune system work like it should. So our T cells are already in the body, but they're deactivated until they see something that's not supposed to be there. So if we get sick, we get a virus, a bacteria, our T cells rev up and they go fight for us. So the cancer cell is making itself look like a normal cell. So if we have a cancer cell, that cancer cell is just circulating, but it looks like it's a normal lung cell. And so the body doesn't know that it's bad. And so that cancer cell is continuing to replicate and grow and replicate and grow. And each one of those cells are replicating and growing. And that's how we get masses. Mm-hmm. And so what the immunotherapy does is it's going to allow the body to recognize and activate those T cells to go work. So what happens in cancer is that some of these cancer cells have shut down the programmed death ligand. So all cells are programmed to die. Mm-hmm. And what happens in cancer is that ligand is shut down, so the cancer continues to proliferate. And so the immunotherapy, we also call that a checkpoint inhibitor, is going to turn that checkpoint back on and allow that cell to die, and the body is going to go in and attack cells and kill it. And so the immunotherapy really doesn't affect healthy cells. It's really affecting the cancer cells in the body. Side effects of that would be, well, we've revved up the immune system too much, and now we've got to shut it down as it starts to cause some internal issues.
Okay. And
and that is rare.
That's rare. Okay. But you'd use like some sort of steroid or something
You're
to
right.
shut
Look
it down?
at you.
Well, I had a leukemia kid, so I just know that much, and that's it.
I was like, I'm impressed. Yes, I know steroids. And so the way I tell it to my patients is, with the immunotherapy, we're revving up the immune system to work for us. So we're pressing on the gas and we're going down the road. We're going down our journey. But all of a sudden, a brick wall has been placed in our road. And before we hit it and we crash and burn, we want to identify that we're about to hit that. And we do that by checking labs, patients telling us their symptoms and being honest with their symptoms.
Yeah.
And what we do is we can push on the brake, which is high-dose prednisone, to suppress the immune system, allow our body to recover, and then we're able to start back on therapy.
Okay. You mentioned being honest about symptoms.
Honest about symptoms.
You run into problems with that, I guess.
We do. You may be surprised. I don't know. Cancer patients want to live. They want to survive. And so they don't want to be upfront and honest with every symptom they have because they're afraid that we're going to stop their chemotherapy. And that means that they're not able to have treatment anymore, which means they might not be here much longer. Patients really get scared and don't want to tell us the truth about all symptoms.
Let me frame this out. So we've got a patient who has been diagnosed, pick a cancer, and they know they're getting ready to start chemo. Mm-hmm. What are things that you're advising them to prepare for that?
Okay. So when patients are diagnosed with cancer, they are going to meet with the physician, and they're going to go over a treatment plan with them. And then after that treatment plan has been determined, they're going to meet with one of our nurse practitioners. We currently do have 4 nurse practitioners in our office, and we do have one in our satellite clinic in Monette and one in Lebanon. And each patient that starts treatment is going to undergo a chemotherapy education session. They are usually about an hour and a half long, where we sit down with them just one-on-one. They can bring their family with them. We allow them to use their phones and FaceTime family members that may be far away so that they can be involved in their care too. And so during that session, we go over each drug that they're going to be receiving. We talk to them about their nausea plan and what they can do at home to help with that. We go over side effects like mouth sores, diarrhea, constipation, all of that. And we tell them what they can do at home. They leave there with a booklet that tells them self-care management that they can do. It's always important to hydrate. So we tell our patients they need to drink at least 2 liters of water a day. unless otherwise contraindicated. But most patients were requiring 2 liters of water to kind of help flush the system and to keep them hydrated, which is really good for all of us to do, not just if we've been diagnosed with cancer.
Okay.
After that, we do want them to be comfortable during treatment. So we encourage them to wear something comfortable. Our clinic personally is always cold. So it's like if you want to bring a blanket or a pillow to make you feel more homey and comfy, that's okay. We encourage them to bring something to keep their mind off of treatment. So if they want to sleep, if they want to read, a lot of my patients knit. We have a puzzle that they can do while they're back there. If they want to do adult coloring books, just anything to kind of keep their mind off of treatment and to help that day go smoother.
Let me circle back. You were talking about how to prepare. They have to take this, a course on getting ready for chemo and what to do. And you said that there was a kind of a nausea plan and that sort of thing. Can you talk a little bit more about what a nausea plan would be?
Yeah, so for nausea, it depends on which treatment they're getting and what IV treatment I'm giving them for nausea. So we do have longer acting nausea meds now, which is very important for patients and people to know that chemotherapy now is not chemotherapy that your grandma received.
What do you mean by that?
So our nausea medications have improved so much over the years. And so I hear it all the time. Well, such and such had chemo and they were sick and they had uncontrolled nausea and vomiting. Well, every patient's journey is different. Mm-hmm. Everyone's body functions are different. And so most of my patients don't experience that uncontrolled symptoms. We have many medications that we can give.
Are there other things to expect, or are there things that people were scared of, but it's actually
at home too?
Yeah.
So after chemotherapy, it's important that we stay hydrated, like I've mentioned many times, and that we take the medications to help with symptom management. And then if the symptoms aren't controlled, that they're letting us know before it becomes worse. Because if we're having uncontrolled nausea, vomiting, we're not eating, we're not drinking, that can actually lead into renal failure, and that can lead into dialysis. And so it's very, very important that patients are letting us know if their symptoms aren't controlled at home. We are going to have symptoms from chemotherapy most likely, but it's can we manage them? And if they're not, that we are being informed so that we can help them manage them at home. Okay. I think it's also important that patients realize that they need to get up and move. So chemotherapy-related fatigue, cancer-related fatigue are all real, and they can be hard. But if we don't get up and we don't move, we're not going to get better. Mm-hmm. So there's a lot of people that think cancer only affects the elderly. And that is not true. We are seeing more and more patients at a younger age. I have 20-year-olds, 30-year-olds, and I've lost them to cancer. So it's very important that we keep in tune to our body. And when something's not right, that you reach out and that you tell your primary care provider, hey, this doesn't feel right. Get it checked out. It may be completely normal, but it's okay to ask for help, especially if you have a family history of cancer. It's very, very important to ask them for help. Another thing I'd like to point out is, we've mentioned that we have satellite clinics, Monette and Lebanon. And I think sometimes people think, oh, well, those are the rural areas. They get treated a little bit differently. But they don't.
Okay.
We do chemotherapy in those clinics. We do labs in those clinics. We have providers in those clinics. We do supportive care. Just because you live on the outskirts of Springfield doesn't mean that you're not going to receive the same care. You do not get subpar care in the rural clinics. You're getting OHA care. We care for our patients. Our motto is, our passion is your life, and that's really how our providers live. I mean, it is. We spend most of our time at the office because we do care for our patients, and their life is so important. And we do want people to know that they are going to get good care in those satellite clinics.
It's good to know, because I do think some people do question that. They think, well, it's rural, so it's not going to be as good as the big city.
Yeah.
But your doctors and your training comes from some of the best places that there are. And so let me circle back to a couple of things before we move on too much. You had mentioned that you can overdo while on chemo, and we were talking about preventative medicine being exercise and doing some weightlifting, and it's more than just walking. but that changes when they're on chemo. You probably want to avoid doing a lot of weightlifting.
You do want to avoid strenuous exercise during chemotherapy. So during that time, it is good to walk and get up and move. You can do light weights to keep your muscles strong, because what happens is we get tired and we don't want to eat because we might have nausea or we have a poor appetite. And that does lead into muscle loss. And so oftentimes we're telling those patients you need to increase your protein. But if you can continue to build with light weights, or even just, I tell my patients, just do squats. Like stand at the counter, hold on, because we don't want you falling.
Yeah.
Or do squats, do leg lifts. Like you can still do something to keep your body active.
I know it's different by diagnosis, but generally speaking, if somebody goes on chemo, how long? I know you said there's ones that go on forever,
right?
But generally speaking, if for certain diagnosis, how long are people on chemo?
So for like colon cancer patients that are stage 3, where we're going for cure, they're typically given 6 months of therapy.
Okay.
We usually re-image about 3 months in. My lymphoma patients, depending on their diagnosis, their regimen, they're usually on treatment for about 6 months as well.
Okay.
Breast cancer patients, it depends on which type of breast cancer they have, and it's going to depend on which regimen we choose.
Let's say they get a good prognosis, right? They come through it, and they're in remission. Or is the word cure used for some?
There are certain diseases that we cure, and that's our goal. There are certain cancers that are going to be in a remissive state. Those are more like our leukemia or lymphoma patients, where we're like, you're in remission, or our myeloma patients, you're in remission.
Okay.
So it does vary. But most patients would say, if they're in remission, that there's no cancer, this is good.
Yeah.
And that's about the best we can be right now.
Right. So they got through it. And now what? Like, do they come back for screenings every year? What other things that you advise them to do?
So after chemotherapy, depending on the type of cancer the patient has, we're going to see them back in the clinic about every 3 months for the first 1 to 2 years. And then we start spreading that out. Depending on the type of cancer they had, they may have imaging, such as a CT scan or a PET scan, but not all cancers require that. And so one of the ones that do not require or recommend, actually, is breast cancer patients. So they actually do not recommend CT scans after they've completed their therapy. When they're considered cured, they've had their surgery, radiation, chemotherapy. There's no cells. There's nothing to say that their cancer is there. And so we typically just follow those up with clinical visits and labs. And a lot of my ladies get very concerned about that. But we don't want to increase the risk of a secondary malignancy by re-imaging frequently. A lot of these patients are not elderly. They are younger and they have a long life to live. And so we don't want to give them a lot of radiation unnecessarily. And unfortunately, what people don't want to hear is if breast cancer returns, it's usually then stage 4 disease and they're going to be on treatment for life. And so catching it early in that setting doesn't necessarily have a positive outcome. It is better, but we're still probably going to be on treatment for the rest of our life. And so by following their liver enzymes or their chemistries, we're able to see, okay, does it look like the cancer spreading to the liver or the bone? We can look at calcium levels, alkaline phosphate levels, and liver enzymes to see if that's looking abnormal. If it's abnormal, then we do scans. Or if the patient has a symptom, then we're going to do a scan.
With all these treatment options, how do you build trust and connection with your patients?
I think it's just the one-on-one conversations. The good thing about being in a community practice like OHA is that we're not driven by how many patients we have to see in a day to be able to to make a quota, to be able to get a raise or a bonus. That is not how we practice. We practice patient first. And so spending the time with the patient, letting them develop relationships with us. We know about their family. They know about our family. That helps tremendously. And our patients, we're helping them get to goals. So if they're not curable and they're like, my goal is to make it to my daughter's wedding, then that's going to be our goal. We're going to do everything we can in our power to be able to get you there. Whether that's a treatment change, a treatment pause, giving you extra IV fluids, giving you steroids so you can go on a cruise. Like, we do what we can to help the patient be able to reach their goals. And I did have a patient last year that her goal was to be able to make it to her daughter's wedding. And she was able to do that. And she came back in and she was like, look at me. I was able to do it. But unfortunately, she fell at the wedding, at the end of the wedding. And that was she kind of went downhill after that. It wasn't because necessarily of the fall. It was just the diagnosis. And she ended up going into hospice care really late in her journey. So she didn't get the full benefits of hospice care. But she got the benefits that she needed with hospice. Her goal was to be baptized before she died. And so the hospice team was able to bring in a pool. They put it in her garage and they filled it up with some water. And the hospice team was able to bring a chaplain in and baptize her. And she passed away the next day.
Wow.
So those types of things that we know that our patients have goals and we're able to help them reach that. That's what's important to us.
Yeah. Boy, there's a lot to unpack with what you just said. So let me try to dissect this into pieces. So we have a hospice, and one of the things that we have been talking about with other guests that have been on is about how there are certain chemos that at a stage that help with symptom management more than they're curative. And so we're not, I guess you could argue that we're prolonging life here to a degree, but the primary goal of the chemo is to help, keep pain under control and that sort of thing. Unfortunately, most hospices can't get involved until the chemo is discontinued. Right. So this isn't how things, this question isn't about how things are currently running.
Right.
If you could choose how that would run and when people could come on to hospice, what things would you change?
So that's a good question. I think we need to do better in palliative care. So patients don't like the word hospice.
Yeah.
They get that connotation that means I'm dying.
Right.
And they don't want to accept that.
Right.
Our patients want to fight. So I've been in other talks where, and even at our hospital, they're like, you guys don't talk about DNR status. Mm-hmm. You don't talk about code status, and they come into the hospital and they're critically ill and you haven't discussed it. Well, it's not necessarily that we haven't discussed it. We have discussed it with our patients, but they want to fight.
Right.
They're like, no, I still want to go on. I want to do this. And we're going to do everything we can. And we can't force the patient to say they want to have a DNR status.
Sure.
So I think right now what this area is really deficient in is palliative care.
Right.
There are other agencies outside of Missouri that have excellent palliative cares. They get on board with the patient the first time they're diagnosed with a metastatic cancer, and they follow them throughout, and they help them get physical therapy, occupational therapy. They help them get what they need. And in this area, we don't do that.
Yeah.
We're very finite we are either home health care or we are hospice.
Right.
And there's that in between. We have a program, but that program doesn't really do anything for the patient, except for giving them a provider maybe once a week. Most often it's once a month, with just them giving them the same information that I'm giving them in clinic.
Sure.
And what we need is for people to come in and say, okay, you're having pain. This is what's happening. This is other options that we can do for you. Let's try this instead.
Right.
Or physical therapy. Patients need to get up and move. Mm-hmm. And oftentimes they're too weak and it's not safe for them to get up and move at their house. But having a therapist that can say, hey, this is what we need to do. This is what I can do to help you. And I have a very young patient right now with a brain tumor that could not move his left side. His left leg just kept getting weaker and weaker. And he's like, Candi, I just want to get up. I just want to move. Like, I just feel like a bird and I'm just in this chair. And so I ended up referring him to physical therapy, which is a soapbox, and I won't get onto that right now. But I have found a great physical therapist that is going to help many, many of my patients in this situation, because he's not a stroke patient. Therefore, neurology services and rehab won't assist at all. And so anyways, I'll let that soapbox go. But I have found a therapist, and he's been working with him, and he actually is up walking in the clinic, like totally walking when he couldn't even move the left side. In the past, those patients would have just been left to the wayside.
Sure.
Okay, you've got a brain tumor. There's nothing I can do for you. This is really not beneficial.
Right.
But we know now, I definitely know that people can be helped. And we just have to find the resources and have the team that's going to go in there and take the risk.
Right.
That financial risk that
Sure.
they're going to help our patients. So I think that's very important in palliative care.
Yeah.
And sometimes, it may be they have a drain in their lung to help with thoracentesis. Well, they need someone that can just help get those supplies.
Right.
Home health care won't do it because it's too expensive. Hospice will do it, but then they can't do it with their chemotherapy.
Right.
And so finding that in between, I think, is more important than just using hospice as the end of life care that it is. We've got that time in between where we really need to focus on symptom management. And I think in cancer patient, it's different. They're trying to make their heart function maybe a little bit better, sustain it. They're giving them inhalers and nebulizers to help with their lung function and trying to get them along the way. But with cancer patients, we're actively trying to help kill some of the cancer cells and still give them better symptom management, like you said,
Yeah.
while giving them better quality of life and hopefully a little bit of quantity of life.
Yeah.
But stopping chemotherapy is such a hard decision for the patients. It's very hard, and oftentimes they don't want to stop until it's the very end.
Let me switch it back to somebody who the prognosis is still good and they're going on to chemo. Are there psychological things you've got to look out for, mental health type things that you have to look out for with some of these?
Yeah, anxiety and depression are very high in cancer patients. And even some of our drugs can intensify that, especially almost all regimens have steroids built in. And some patients will have a lot of increased anxiety with that or have mood changes with that. And so we do have to monitor that. Oftentimes we refer those patients to either the primary care if we can't manage it with a single antidepressant or anxiety medication, or sometimes patients even need counseling.
Do you know if there are any support groups that meet, like for breast cancer or anything like that?
So the Breast Cancer Foundation of the Ozarks, they
Okay.
have a breast cancer support group.
Okay.
Unfortunately, when COVID hit, all of the cancer support systems groups kind of went to the wayside,
Okay.
and a lot of them did not pick back up.
Really?
The problem with those mostly is funding.
I
And
see.
So getting someone to fund it to keep it going. I think Cox has a caregiver support group that meets. But
Okay.
at this point, there's not a lot. And unfortunately, patients are looking towards blogs, Facebook, TikTok to
Yeah.
find their source for support.
With the evolution of cancer treatment in your career, what excites you the most about the future of it?
So the immunotherapy has been so exciting. I've mentioned that. With new technologies, we're actually able to give treatments that normally would take 8 to 9 hours in the clinic in a sub-Q shot. So now
Wow.
taking 5 minutes in the clinic. And there are some new drugs that are coming out, well, not new drugs, they're already on the market, but using that technology of injections, which is very exciting. Biosimilars have been out for a couple of years now. We're using biosimilars to help decrease the cost of healthcare. So they have their drugs that are very similar to the original product, not necessarily a brand generic change, but they're very similar. So they may have a little bit of a different molecule in them of how they get to the end product, but it's still the same mechanism of action, the same side effect, and same efficacy. But that's decreasing the cost of healthcare. And so that's exciting. Clinical trials are always going on. So just finding out new information, new treatments that can help patients. One of the cancers that really doesn't have a lot of treatment options is pancreatic cancer. And so I think there's a new one that they're looking at to possibly come on the market for pancreatic cancer. So that's exciting. It may not give a long period of extra life, but extra life is very, very important for these patients, especially, like I said, if they have a goal, if they have a high school graduation they need to see their kid get to, or I had a patient who had breast cancer and was considered cured. She had no evidence of disease. And a few years later, unfortunately, it came back, stage 4. And she's doing wonderful, but she's like, I need to see my kids grow up.
Yeah.
That's all I need. Can I at least get my kids through high school? If I can just get that, I would be happy.
Wow.
And so hearing those types of stories, like, of course, we're going to do everything we can for each patient, but, I'm going to try my best to get you to that. And it's looking really good right now.
Are there any symptoms in particular that they need to be looking out for as a young adult?
So a lot of my younger patients, with the exception of like a Hodgkin's disease, which is in the younger population in general, but breast cancer patients and colon cancer patients, those are 2 that I'm seeing a lot younger. And so making sure you're doing your breast exams. If you find a lump, go get it checked out. That's very, very important. Unfortunately, mammograms are for those that are 40 and older, and so getting it covered is very difficult. But checking with your primary care doctor, saying, hey, I need to have this evaluated, very important. Colon cancer, if you're seeing a change in your bowel habits, you need to let someone know. If you're having blood in your stool, that is not normal and that needs to be checked out.
Okay. I do know that, because I've checked into this a little bit myself, that sometimes you can reach out directly to, about CT scans or that sort of thing to pay out of pocket. And sometimes the cost is not as prohibitive as you might think.
Yes.
And so that's just an avenue I wanted to mention.
Yeah.
Hope for the Journey Foundation. Tell us all about it.
So Hope for the Journey Foundation was developed a few years ago by our clinic. I am lucky and blessed to be able to serve on the board of the Hope for Journey Foundation. So what this is a foundation that is going to help patients with their non-medical bills. And so it does offer up to $1,000 a year to help with non-medical bills. So it may be that you need new cars, you need tires for your car to get to treatment, or maybe you need gas, or we've helped patients that needed a ride to MU for radiation therapy. We have helped many, many patients be able to help pay their rent, their utilities. And so this is just an extra support that we are very happy to be able to share with the community. This is not just for my patients at OHA. This is for all patients in the Springfield area and some of the outlying communities as well. All you have to do is apply. There's an application. It goes through, I think it's the Community Foundation.
Community Foundation of the Ozarks?
Yeah. So they get the application, they go over it, and then it's sent to the board to review. And so that's very exciting. We've helped so many people. And so you can donate to that too through our website, or you can apply for it. One thing that I would like to plug for OHA is that we are set apart from other oncologists in the area, and that we do have our financial team on site. So we do have financial counselors, reimbursement agents that can meet with our patients. And so they actually meet with the patient before their treatment to let them know what the cost is going to be up front, so they know what it looks like going into it. We help our patients get grants to help get copays. Or certain agencies will actually have grants for malignancies like the Leukemia Lymphoma Society, and we'll help patients apply for that. We also have on-site lab. And so in our clinic, you're able to come in, get your blood counts that day, and we can see those results before we approve your treatment. So that hopefully will allow you not to have to come to the clinic multiple days in the week, which not all clinics can do that. So that's very special that we can get a CBC within 5 minutes and a CMP in about 45 minutes. So that's really important to know about our clinic and how it sets us apart. We do in-house biopsies for bone marrow. All of our physicians will actually do a bone marrow biopsy for our blood disorder patients. And so that's really exciting. We also have DigniCap. So some patients will lose their hair during treatment. And a lot of my breast cancer patients, we're taking so much from them. And, they take their breasts, we take some of their independence away, and we take their hair away. And one thing that they can do if they can afford it, because right now insurance doesn't really like to pay for it, but we have a Dignity Cap, and it's a cooling system that the patient can wear during their treatment. And so they do that, and it decreases the shedding of their hair and decreases their risk of having actual complete hair loss. And so some of my patients will use that. And that's pretty unique. I think we're probably the only one in the state of Missouri that actually has one of those. So that's very exciting. We do have what we would call more of an on-site pharmacy. So it's not on-site in Springfield, but in our Florida offices, we do have pharmacy team that will actually dispense oral chemotherapy. And so this gives the patient an extra layer of education and ease. So we don't necessarily have to go through a lot of different insurances to be able to get the drug delivered to the patient. Because with oral chemotherapy, that's not going to be at our local pharmacies. Only specialty pharmacies are going to have those. And so if we can send the prescription to our pharmacy, we can get the prior authorization, we get the PA, which is the prior authorization, and then oftentimes financial assistance. Oral chemotherapy, it's wonderful for a lot of patients. However, it's very expensive. And so just today, I'm dealing with trying to get samples for a patient who his prostate cancer drug is going to cost him $1,700 a month. And he can't afford that. And which most of us couldn't afford that, at least not for a long period of time. And he's going to be on this until it doesn't work. And so I'm working on getting a sample for him as we're working on the financial process of getting him a copay card or some type of assistance to help pay for the medication. So our pharmacy team is able to help do that. And then they educate the patient, and they're there 24/7. If someone needs to call, they can call in and get their questions answered. So it's an extra layer to their team. And so that's really important. We also have dietitian that we consult with. That's a televisit, and that's a no charge. That's just a service that we offer to the patients because, again, it's not really reimbursed, but we do feel that it's important. And so we do work with our dietitian as well to help patients. So in their cancer journey, when they are having difficulty eating, different side effects that we just aren't able to manage just with medication, they're able to help us with those food choices for the patients. And especially with high protein, they're the best to help us with that.
So the telehealth, does it happen in the office or is that in their own home?
That's in their home.
Okay, that's nice.
We'll just say we don't charge for the telehealth. And so to my knowledge, that did not change today as all the other recommendations for telehealth changed. Since it's a no charge, I have not heard that that's going to be any different.
You're so knowledgeable, and I'm so grateful for you being here and helping inform on so many different issues. And I just want to thank you for being in this business and being on this podcast.
Thank you.
Before we wrap up today's episode, I want to remind you that you're not alone on this journey. Right here in the Ozarks, there are incredible resources ready to support you every step of the way. From expert care at Oncology Hematology Associates, Cox Health Cancer Services, and Mercy's C.H. Chubb O'Reilly Cancer Center, to groundbreaking work from Cancer Research for the Ozarks, Breast Cancer Foundation of the Ozarks, Missouri Cancer Associates, and the American Cancer Society in Missouri. We have web links in our episode description. If you or someone you love is facing cancer, please take a moment to check out these resources, connect with their teams, or join a support group. Help, hope, and healing are closer than you think. If you enjoyed today's conversation, make sure to like and subscribe so you never miss an episode.
And we'd love to stay connected. Follow us on YouTube, Facebook, and on Instagram at In Good Company Elder Care Podcast.
You can also find us on X, formerly known as Twitter, at IGC Pod, and on TikTok at IGC Elder Care Podcast.
Thanks for tuning in to In Good Company Elder Care in Your Backyard. I'm John Ray, and I've been joined by my amazing co-host, Spencer Ernst. Special thanks to our executive producer, Alex Wallace, for helping bring this show to life. Until next time, take care, and remember, you are always in good company.